I think that we, as I said, are in the cusp of a transformational age for multiple myeloma patients. As these new immune-based therapies are coming out, we are now going to see these moving into earlier lines of treatment. We're already probably in the next year or so going to have the ability to give CAR-T cells in second line and third line.
Mhm.
Uh, the use of bispecifics in those lines will follow. Ultimately, these are going to be moving into first line treatment. The question is, will we start seeing more patients being cured? When I say more patients, we certainly do have patients that are already cured of myeloma, patients who've been in remission for 2 decades or more. We have living proof of such individuals. And I think that what we will see, hopefully, is a greater proportion of patients
Mhm.
uh, now being cured. Now, whether these treatments displace what is still felt to be for most people the standard of care, if possible, which is stem cell transplant, or they're going to be used in conjunction with stem cell transplant to achieve these cures, remains to be seen.
Hello and welcome to Q Talks. Today we are discussing new developments that happened in the world of myeloma management in the past few years. I'm Shweta Mishra, and we have with us today Dr. Ravi Vij, Professor of Medicine in the Division of Medical Oncology at Washington University School of Medicine and founder of the nonprofit organization mycancerhaven.org. Joining Dr. Vij on the panel is Jack Aiello, a leading myeloma patient advocate who is involved with several cancer advocacy organizations. And I welcome you both, Dr. Vij, Jack, to the panel today. Thank you for joining.
Thank you for the
Thank you.
invitation.
Thank you. Dr. Vij, to start with, I want to mention that the median survival for myeloma patients has now increased to about 8 to 10 years, compared to only about 3 years, right, that we had about 2 decades ago. And the several agents and treatments that FDA has approved over the past decade has contributed significantly to this improved outcomes, right? So could you please briefly share some highlights of the new developments that happened in the field of myeloma management in the past few years?
Yeah, I think that the management of multiple myeloma has been revolutionized in this millennium. First, in the first decade, we saw the advent of drugs like proteasome inhibitors, immunomodulatory drugs that changed the landscape of treatment. About 6 to 7 years ago, we started seeing monoclonal antibodies appear, daratumumab, isatuximab, Simplicity, and these further improve outcomes for patients. And now we're entering a new era of immunotherapy, and I think the best is yet to come. And we've only started to see the beginnings of the next major, I would say, leap in outcomes for patients with multiple myeloma. And the main thing that I think people are most excited about right now are CAR-TCells, bispecific antibodies. But there are other advances that are also happening concurrently, including drugs like CellMods, venetoclax for patients who have the 1114 translocation that will also be coming to market in the not too distant future.
Thank you. Thank you for that rundown, Dr. Vij. I know Jack will have more specific questions on this to you. But I was recently reading up and found that a group of chemists, I believe from MIT, they have designed a nanoparticle which kind of looks like a bottle brush, and they can load multiple cancer drugs on it and deliver combination of drugs to the myeloma cell. So it's also fascinating. Could you talk a bit about how nanoparticles work to treat cancer, and how do they solve the limitations of cancer, conventional cancer treatments, and also talk about a bit, about the progress that has happened in the field of nanotechnology for cancer?
Yeah, I think that nanotechnology has great potential in drug delivery. The fact is that nanoparticles are particles that are smaller than the breadth of human hair, and these are the agents for drug delivery. We have actually some nanoparticle related drugs already on the market, For example, liposomal doxorubicin, which was actually approved for multiple myeloma, is actually a nanoparticle based therapy. So nanoparticle based therapies have been, and there are a number of other liposomal products that are used in different cancers. But yes, now the field is moving towards even more remarkable advances. And the use of these are because you can actually coat these particles with targeted agents, and they can then go and deliver the agents specifically to the target of interest and have little in the way of off-target effects. So nanotechnology, I think, is something that holds great promise. Here at Washington University, we actually had for 5 years an NIH-funded grant looking at nanotechnology for treatment of multiple myeloma, and a lot of preclinical advances have been made, and hopefully these will translate into therapeutics in the years to come.
Right, thank you. And before I pass it on to Jack, I wanted to talk to you about the nonprofit mycancerhaven.org that you started, Dr. Vij. Could you talk about its objective a little bit and how it will help patients and physicians advance myeloma care?
Yeah, so thank you for asking. So this is a not-for-profit that I actually established in 2017. The mission of the not-for-profit is to provide a custom-designed, curated, and moderated platform where not only cancer patients, but cancer-focused experts, researchers, and organizations can come and create cancer-specific ecosystems to enable the dissemination of information, educational, and research initiatives. So it is meant to bring all the stakeholders together. We have started in myeloma in January this year, and I'm very grateful to Jack, who's been very helpful in getting this effort off the ground as well. And what we have on the platform are educational tools, including videos. We have physician experts and other experts that have started producing blogs specifically directed to a patient audience. There are other platforms certainly out there, but they don't usually have a cancer focus, and some of them don't have the ability then to provide vetted information. For that reason, we think this would be a unique platform. We also are able to provide up to the minute curated Twitter feed and news feed. Patients have the ability to form groups and also message each other. We engage the patients with educational quizzes, and actually one of the other important initiatives is to get the patient's perspective. If researchers have questions, we can pose them to the patient community. We also are going to be opening it up to leukemia and lymphoma this month, and hopefully in the months to come to additional cancer types as well. So thank you for allowing me to talk to the audience about this platform. It is accessible right now only in the United States at mycancerhaven.org website.
Thank you. Thank you for sharing that with us, Dr. Vij. Good to know the information about it. And I guess with that, I will now pass it on to Jack to take the discussion forward. Jack, please take over.
Thanks, Shweta. And Dr. Vij, thanks so much for being available for this talk. I was diagnosed more than 28 years ago, and it's just amazing to see the continual evolvement of treatments and the increase seemingly in treatments for myeloma over the past few years. For example, if I'm a newly diagnosed patient, I'm going to get what's called induction therapy. But these days, if I'm getting educated, I'm hearing that there are, for transplant eligible patients, 3 drug regimens or 4 drug regimens, and there are different regimens for non-transplant eligible patients for induction. Can you talk about that? And how do you decide, even at induction, what treatment to take?
Yeah, that is a very good question. And you're right. I think what we are seeing is that the transition in the transplant eligible patient from 3 drug regimens to 4 drug regimens is ongoing. In the community, 3 drug regimens are still very commonly being used, but at least in academia, we have transitioned to 4 drug regimens based on the observation from several clinical trials that the depth of response, including minimal residual disease negativity, is much higher with 4 drugs, including the antibody daratumumab or isatuximab. And with that, we anticipate that we will, in the years to come, be able to show a much greater time of disease control and hopefully also longer lifespan for our patients. It is just that it will take years to demonstrate that. So either we can rely on what we call surrogate markers that have in the past withstood the test of time and anticipate that we are doing good by making this transition already. As regards those that are not transplant eligible, there at the moment, 3-drug regimens are the standard of care, but there too, we are anticipating trials to read out very much in the near future, where 4-drug regimens may surpass the 3-drug regimens of today. The 2 3-drug regimens that are probably most commonly used today are daratumumab with bortezomib and daratumumab with lenalidomide and dexamethasone, and lenalidomide with bortezomib and dexamethasone. There's no consensus on which is the best, but I think that more and more people are definitely using 3-drug regimens.
The unfortunate part is that most patients, well, fortunately, will do well with any of these regimens, but at some point they probably will relapse. Their treatment stops working, even if they're put on maintenance treatment, which is quite common. So for those relapse or refractory patients, what factors do you consider when making the next treatment decision, since there are even more treatments available at the relapse refractory stage?
That is very true. So the fact is that it is actually a good problem to have, that we have an abundance of riches. We have a lot of different options to choose from. And once again, if there is a little consensus sometimes in frontline therapy, the consensus in later lines of therapy is even less so. And the treatment of myeloma is as much art as it is science. The use of 3-drug regimens, again, in later lines of therapy, 2nd, 3rd line, has now replaced 2-drug regimens that were used in the past, after a number of trials have shown that 3-drug regimens outperform 2-drug regimens. In the 2nd line space, we have the ability to give daratumumab-based 3-drug regimens, daratumumab with carfilzomib and dexamethasone, daratumumab Velcade and dexamethasone, daratumumab with Revlimid and dexamethasone, and a later line of therapy, also daratumumab with pomalidomide and dexamethasone. And I think that the daratumumab-based regimens have been the mainstay of 2nd-line therapy for the last few years, because patients that today are seeking 2nd-line therapy are not what we call quad refractory. They are not usually exposed or refractory to daratumumab because they started their cancer journey in an era when daratumumab was not commonly used in frontline. So which of these daratumumab-based regimens to use is very much dependent on the physician, but also on a number of patient characteristics, like what they have had in a prior line of therapy, what their comorbidities are, what their performance status is, what their social situation is like. So a number of factors go into this decision-making. Also, in somewhat old and frail patients, sometimes 2-drug regimens are still used. As you get into a later line of therapy, you see once again what you used in your 2nd line, and you try to come up with a new combination for 3rd line of treatment. Obviously, when you get into much later lines of therapy, like 5th line and beyond, we are now seeing an abundance of new options of being available. We've had, for the triple class refractory patients, selinexor that was marketed several years ago. It is given not as a dual therapy these days, but as part of 3-drug regimens often. And BCMA-based treatments are really where the focus has shifted in that line of therapy now. We now have 2 CAR-TCells that are approved. They have been in somewhat short supply, but the good thing is some of the production constraints are now seemingly easing. So hopefully this will become available to more patients in the very near future. And then in the last few months, we've seen the approval of the first bispecific to BCMA, Teclistamab, which offers patients a ready off-the-shelf availability of therapy, which also offers patients the potential to be treated closer to their community oncologists and not necessarily in large academic centers once the setup in the community is complete to manage CRS and some neurological toxicity. So a long-winded answer to your simple question, but unfortunately, there is not a simple answer to that question.
Well, that's really important what you're saying in terms of having community oncologists able to give these new treatments because we need to reach as many myeloma patients as possible. You mentioned earlier in one of your answers to Shweta about the two new exciting areas, CAR-T therapy. We have a couple of FDA-approved CAR-T therapies in the US. And bispecifics, we already have one bispecific approved in the US, as well as two approved for accelerated approval. So, and then many more of these CAR-Ts and bispecifics in clinical trials. So maybe you can just, for the new patient, give a quick summary of what CAR-T and bispecifics are, and then what did we learn from the recent December's ASH, American Society of Hematology meeting about these treatments going forward?
Sure. So CAR-TCells are state-of-the-art technology whereby we can modify a person's immune system to recognize the cancer. What is done is we collect the immune cells through a process called pheresis. These are then shipped to a manufacturer, and they're expanded and genetically modified to recognize the cancer. It takes anywhere from 4+ weeks to get the processing of these complete today. Once these are ready to be shipped back, then patients are given some outpatient chemotherapy generally, and this is not of the intensity of stem cell transplantation. And thereafter, they're admitted for the infusion of the CAR-TCells, which go in less like a stem cell infusion, just like any blood product infusion. And these cells then multiply in the body to recognize the cancer. And depending on the type of CAR-T cell being used, anywhere from 24 to 48 or as long as 7 days later, patients develop often an entity called cytokine release syndrome, wherein when these cells are recognizing their target, they secrete chemicals that make the body run a fever. Sometimes patients end up on a little oxygen and drop their blood pressure. It is rare to end up in an ICU setting, but these are also associated in some cases with transient period of confusion, which can be a little distressing to the family members, but in nearly all cases, this is transitory and resolves within a few days. And what we have seen is with this, what we call one and done approach, anywhere from 1 to nearly 2+ years of good disease control. So patients don't need to be tied up to treatments for extended periods of time. And this is in later lines of therapy when patients have progressed through 4 prior regimens. It is anticipated as these move into earlier lines of treatment that the value proposition would be much greater. As regards the bispecifics, those are, as we had said, off-the-shelf therapies. So whereas there is a lag period to get a CAR-T because of insurance approval, production issues, and some patients whose disease is progressing rapidly may not be able to wait long enough, a bispecific is available very quickly for administration to the patients. The one that is currently approved, called Teclistamab, requires 3 ramp-up doses, and during which, once again, some CRS and rarely neurological toxicity may be encountered, but much less intense than seen with a CAR-T. And once the patient has received the first full therapeutic dose, then patients literally do not have any other problems thereafter, and they can be managed as an outpatient with, at the moment, with Teclistamab weekly injections. this is something that, again, provides prolonged benefit, a year and a half on an average, and some patients even more. With bispecifics, as with CAR-T cells, what we see is a very rapid decline in disease burden in those patients that are going to respond. For those that don't have as good a response, we see a relatively rapid recurrence. But the good thing is, for the majority, where the disease goes into a deep remission, the remission periods are very long.
So just to remind folks, CAR-Ts are kind of a one and done. I get it. And then theoretically, I'm not on treatment anymore until perhaps the myeloma scene is coming back, versus bispecifics are infusions that are given every couple of weeks, let's say, and these continue until what's called progression or the disease coming back. Is that correct?
That is very true.
And do these all work in the same ways? Do they find the myeloma cell in the same way? And can I use both both of these treatments?
That is a very good and excellent question. So the fact is that as far as the BCMA-based treatments go, I think quite a few patients are going to get more than one different modality of treatment directed to BCMA. What the optimal method of sequencing still remains to be worked out, but the early data suggests that once you have had a CAR-T and responded, then going with a bispecific offers a fairly good chance of response. On the other hand, if you get a bispecific and you progress, your disease progresses on a bispecific, and you go to a CAR-T soon afterwards, the CAR-T's efficacy is somewhat limited. But if there is a gap between the period of exposure to the bispecific and CAR-T infusion, the longer the gap, the longer the chances of a CAR-T helping you. The good thing is, as you hinted about, do these all work in the same way, that we have actually new targets that we have identified that are also the subject of bispecific and CAR-T development. GPRC5D, Teclistamab, a bispecific to this, has now been put before the FDA, and if all goes well, may actually be the second bispecific to myeloma to be approved sometime later this year. And the CAR-Ts to GPRC5D have been presented. Both of these modalities, once again, work in the majority of patients. And what is very exciting is they work even in patients whose disease has progressed after exposure to a BCMA-based treatment. So I think that we have now got not only BCMAs, but we have other targets. FcRH5 is another target. Covestamab, a bispecific antibody to the FcRH5 receptor, has also shown very robust activity. What we, however, need to be cognizant of the fact with bispecifics is that there are some other side effects that may be needing to be tackled. With GPRC5D, the issue with skin and nail toxicity has been demonstrated, and then an entry called dysesthesia, where patients are not able to swallow food and lose weight, can be an issue in a proportion of patients. Also, as a class, BCMA bispecifics seem to also have a higher rate of infections, and we are only now starting to see some of the infections emerge that we usually have seen in the post-allogeneic transplant space. CMV, adenovirus infections, pneumocystis carinii infections. These are things that we don't usually see in a non-allogeneic transplant population, but we have started seeing them in some patients with bispecifics, which has brought up the question on that should bispecifics be given till progression? They do a great job in a lot of patients, and they are in MRD negative complete remission within a few months of starting therapy. So some are postulating that we may go back to the old paradigm where you treat, you give a treatment-free interval and re-intervene. So we'll have to see how this story unfolds.
So one of the keys I hear you mentioning is developing treatments that pick these targets. You mentioned BCMA. That's one of the antigens found mostly on myeloma cells, but not elsewhere. Versus where there's a different target like the GPR5D or whatever that was, that might be found on other cells, and therefore it might lead to different types of side effects. Is that correct?
That is very true. GPRC5D expression on skin, nail, and the epithelium of the tongue. Now, BCMA is fairly specific to the myeloma cell, but also some off-target expression in the basal ganglia of the brain has been demonstrated. And so one needs to be a little vigilant about its use and look out for those Parkinsonian symptoms that have been reported in a few patients in clinical trials.
Okay. And you mentioned MRD earlier, which stands for either minimum residual disease or measurable residual disease. But can you explain what that is, and should patients be requesting this MRD test, and do you use it to help figure out what treatment might be given next?
Sure. So as you said, minimal residual disease, now more commonly called measurable residual disease, is a state-of-the-art technology that allows you to detect one cell abnormal in 100,000 or one cell abnormal in 1 million. To put in perspective, when we look at cells under a microscope, which has been the conventional definition of a complete remission, you count 100 cells and see if you see any cancer cell. So these technologies are able to detect cancer at a much lower level than has been previously feasible. There are different technologies, flow cytometry or next-gen sequencing-based technologies that are being employed. The fact is indisputable that these tests are predictive of long-term outcomes. Patients who achieve MRD negativity do far better than those who are MRD positive after a finite period of treatment. What we still lack is proof that for patients who are MRD positive, giving them more treatment to achieve MRD negativity changes their long-term outcome. And this is being studied in clinical trials. However, already quite a few physicians, there's no consensus on this field again, feel that especially for patients with high-risk disease, it may be worthwhile giving additional treatment to try to deepen the response, because high-risk disease patients, unfortunately, do have shorter period of remission. And these are usually the patients that have genetic abnormalities like p53 deletion, 414, 1416, 1420 translocation. So for them, maybe this is already something that we can avail of. We also know in clinical trials, we are seeing some early trials looking at CAR-T being given for patients who are MRD positive to turn them to MRD negativity. And early data from such studies suggests that there is perhaps some superiority to that approach. The physicians are still not lacking a consensus on whether MRD is ready for prime time clinical use in all patients. There are some physicians who are already making decisions about when to discontinue maintenance therapy based on MRD negative status. The fact is that this is being addressed again in clinical trials. However, it will be several years before we have firm results from prospective clinical trials to answer this question. But we already have often patients who are having side effects, and they are, on one hand, scared to stop their treatment. On the other hand, their quality of life is suffering because of the maintenance therapy they're on. So again, without any definitive proof, I think that in such a situation, checking MRD and 2 successive points, 6 months to a year apart perhaps, and stopping it if you're MRD negative may offer the best solution for those patients. And others are using MRD to monitor patients on a longitudinal basis. When you go from MRD negativity to MRD positivity, should you intervene or change treatment? This again is something that there is no proof right now is something that will make a difference long-term in a patient's care. But these are the questions that are needing to be answered in the trials in the years to come.
So it's interesting. More treatment options, both for induction and for relapse patients, lead to more questions being asked and need to be answered. But it's exciting. I appreciate your answers, and I'll turn it back over to Shweta.
Thank you. Thank you, Jack. Dr. Vij, it was great listening to both of you. Dr. Vij, before we conclude the talk today, it would be great if you could talk a bit about your vision. What is your vision for improving myeloma treatment for the next decade?
I think that we, as I said, are in the cusp of a transformational age for multiple myeloma patients. As these new immune-based therapies are coming out, we are now going to see these moving into earlier lines of treatment. We're already probably in the next year or so going to have the ability to give CAR-TCells in second line and third line. Mm-hmm. The use of bispecifics in those lines will follow. Ultimately, these are going to be moving into first line treatment. The question is, will we start seeing more patients being cured? When I say more patients, we certainly do have patients that are already cured of myeloma, patients who've been in remission for 2 decades or more. We have living proof of such individuals. And I think that what we will see, hopefully, is a greater proportion of patients now being cured. Now, whether these treatments displace what is still felt to be for most people the standard of care, if possible, which is stem cell transplant, or they're going to be used in conjunction with stem cell transplant to achieve these cures, remains to be seen. But I think that immunotherapy holds great potential, and who knows what else will come down the pike in the years to come.
Right. Thank you. Thank you, Dr. Vij. Thanks for all the information you shared. Great session, and we learned a lot. Jack, thank you for guiding the panel with your insightful questions, and we will make this talk available on freetalks.com very soon. So until we meet next, thank you everyone, and have a great day.